Thank you very much for the kind words, and thank you for inviting me. And first of all, an apology for not presenting my talk in French, but if you had heard my French, you would be grateful that I'm not speaking to you in French. I'm wanting to talk about some work that I've been involved with some colleagues over the last 5 years, reviewing the evidence of effective interventions in our field. Before I proceed, I've got a slide about declarations, which, to make it simple, I've grouped these as involvements I've had with government agencies, involvements with pharmaceutical industry, with service provider or treatment agencies, and then with policy groups and with charities. And this is available publicly if people want the details. So the basis of my talk is the book that was published last year on drug policy and the public good. And it has an earlier sibling, which is the alcohol work that was done to produce the book Alcohol Policy and the Public Good, and the sequel to that, Alcohol, No Ordinary Commodity. And the objective was to produce a readable book for the intelligent general public as well as the professional field, which brought together the international literature and evidence into a synthesis. So on the one hand, we were wanting to bring clear statements of where there was a strong evidence base. We also wanted to bring clear statements about where there was evidence of no benefit or a very little benefit, and also to highlight the areas where there was insufficient evidence. I presume that you will all already have a copy, and if you don't, you will want to rush out and buy a copy of the book. And if you do, if you choose to do so, the last time I looked, it was very cheap on Amazon. It was cheap when it came out, and it's become even cheaper if you buy it through Amazon. The work was an extremely interesting exercise. There were a number of co-authors, and I've listed them here, and they each bring a distinctive, different scientific perspective to the work of the group, and we regarded ourselves as a sort of an invisible college where we were working together, even though we came from very different parts of the world. And we had a number of meetings where we spent time together, but we also had a lot of meetings enabled initially by telephone and then by Skype. And the work itself was interesting because we all brought preferences that we had for the conclusions, and our fellow authors would then remove conclusions that we wanted to include where there wasn't a sufficient evidence base. So we have people from the treatment sector, from the law enforcement and drug control sector, from the prevention sector, with a fairly strong international representation. So I'm going to take you through the purpose and objectives, the way in which we went about the work, the measures and the evaluation, and then finally the conclusions that we were able to reach. It's often quite a problem, as many of us have been advocates in the field arguing for better resources, and there's a tendency for people to say, well, it's been shown that treatment works. And of course, this is very reassuring that in some circumstances treatment does work, but we need much greater specificity about that statement. It's as naive as saying that antibiotics work or surgery works. That's only true if you happen to have the condition for which antibiotics or surgery are applicable, and if the intervention is given at the right time. Within the addictions field, we also have some conditions where there is no particular special treatment. There may be many things that we can do to help somebody in their difficulty, but there isn't a specific treatment for the nature of the problem they have. And we also fail to recognize the importance of the huge variability in quality of delivery. These would be obvious observations if we were looking at other areas of healthcare, if we were looking at surgery or a medication-based treatment, but we fail to realize that in our field. And you can't take efficacy from one area of our field and presume it's universally applicable. Quite a lot of colleagues wondered why we were bothering to look at the evidence, because they would say, I already know what works. And this is unacceptable in other areas of healthcare, and it's unacceptable in our area. And it leads to a dangerous arrogance, a failure to realize that a lot of the treatment we provide is probably of very minor significance, whilst other components may be important. And our awareness of the difference between the two is crucial if we're to actually concentrate our resources on the bits that make a difference. There's also almost universal statement that we can't afford to do research. In a way, any company that was approaching the addictions problem would presume to put aside part of their budget for research and development to improve their product, and that's essential in our field. But we need to realize there's different types of research. There are some types of research that are just for the sake of somebody's master's project, or maybe hugely interesting to that person, but don't actually advance the field very far forward. There are then some types of research that are crucial for our scientific understanding of the problem, but still don't necessarily advance our ability to intervene. And then there are types of research which are to do with the actual delivery of interventions or improving the interventions that occur. The second and third seem to me crucial parts of our planning of what we provide. Increasingly, we're reminded of different types of evidence, and they're often ranked hierarchically according to, with meta-analyses of randomized trials being seen as the highest level, moving down to the bottom category, which is little more than saying that I met someone on the beach this morning who told me their opinions. In fact, for this book, we looked through quite a variety of different types of evidence because, in our opinion, the best study design is not necessarily according to this hierarchy. It depends crucially what question you're trying to answer. For example, if you're looking at mortality rates, it would be difficult to be doing that in a randomized trial way. So we looked at a variety of different treatment approaches, but we were always mindful of the scientific quality of what we were examining. And just to guide you through how the book's constructed, there are different sections. I hope you can just about see it down the left. So we look at international evidence and the quality of it around the prevention territory, services for drug users, grouped into the actual interventions themselves and then the organization of them, supply control, prescription regimes, and then criminal sanctions and interdiction. And let's take you into just one of those areas. If we look at areas like opiate substitution treatment or methadone maintenance or buprenorphine maintenance, we take the reader to what seemed, in our opinion, to be the key issues that the reader would want to know about, and we give them the essence of some of the key studies that answer those questions. So what do we know about methadone versus detox, or methadone versus no intervention, or the importance of dose or of psychosocial components of treatment? So it's a quick summary for the reader to understand what's out there as evidence. And then similarly in schools or community prevention programs. I'm not going to go through the details of this. You have to go and get your book if you want to get the detail of it. But to take you into a little bit more detail, so as a result of that, when you look at it with methadone maintenance, you're able to look at the evidence, and there's a good quality of evidence for a consistent finding for reduced heroin use, reduced other drug use, reductions in crime, HIV infection and hepatitis. And we then also looked at the extent to which this was applicable cross-nationally and in different cultures and settings. And those are generally summarized in the tables in the books. Right, I'm going to skip us through to how we then went through a synthesis exercise to reach our overall conclusions. This bit of the work was the more simple bit, where we were listing what we thought were the conclusions, but when we then tried to compare the strengths of conclusions that we wanted to reach in the prevention area versus the treatment area versus the law enforcement area, that proved much more difficult. We also had sort of summaries around needle and syringe exchange schemes, peer self-help organizations, and so on. We identified a number of significant systems changes that had happened, and it was an area that we were keen to bring to the book. There was much more than just treatment as if it was located in the relationship between a clinician and a patient or client. We were aware that the overall organisation at city or national level was a crucial part of it. And we looked at what had occurred in both France and Switzerland as being good examples of a major change in orientation that had occurred, and that they could be studied in just the same way as a change of an individual's treatment plan. We also saw the introduction of the drug court system in the US as a similar example, and the efforts in the UK of introducing fairly directive clinical guidelines to practitioners and studying the extent to which they changed behaviour was another example that we gave the reader. So overall, there was clear evidence that some areas of treatment and wider interventions had a strong evidence base. What was striking was that the strongest evidence for specific interventions was actually in the heroin addiction or the opiate addiction field. And then there was also strong evidence that there was a diversity, a range of benefits, not only individual benefits, but societal crime reduction and reduction of spread of HIV and other diseases, and also that the widespread introduction of harm reduction programs, most visibly needle and syringe exchange schemes, had been associated with reduced HIV, individual risk, and population transmission. I think I'll skip on through these. We drew attention to issues around service provision to do with actual access to services and their coordination, and also challenges that existed around how one dealt with proposals for coercive provision of treatment and where stigma existed as deterrents to access to services. So then in the final section of my talk, I'll describe how we tried to bring this evidence together into some conclusions. And we were essentially looking for key messages that we could give, in particular to politicians or to senior administrators in government about messages that they should be able to take away with good confidence. So we were looking for conclusions, not just ones that we wanted to communicate, but ones where, if challenged, we could say there was a good scientific grounding for the conclusion and that it should inform the formation of drug policy. So firstly, there's no single drug problem in society. It isn't a single thing, and that there will be no single magic bullet that will solve the drug problem. And that then makes it very similar to other challenges in the health arena, like the challenge of how does one deal with cancer, and it's only when you appreciate that there are many different types of cancer, where the way in which you approach them and the advances that you make are achieved by different methods and with different successes across those, the different specific forms of cancer. And that seemed directly comparable to how we might view the multiplicity of variations of a drug problem. We were reminded that Mencken had said that for every complex problem there is an answer that is clear and simple and wrong. And there is something terribly attractive to politicians about being given simple solutions which they can present politically. And part of our task is to give the unpopular message that the situation is actually more complicated than that. You also need to look much more widely than the areas that are considered as drug policy. That if you're looking to address drug problems which overlap a particular intensity in areas of deprivation, where not only is the prevalence of the problem larger, but the difficulty in then disengaging from that problem is even greater, you need to consider the wider socio-cultural context, and some of your responses of importance will be responses that are outside orthodox drug treatment or drug policy responses. Employment and education are sort of very obvious examples of that area. We looked at the evidence that existed for the considerable efforts there have been to curtail cultivation of drug production in poorer countries as a means of reducing the size of the drug problem, and we found very little evidence that this had benefit in either the producer country or in other countries, and we were sufficiently convinced by the evidence that it was a poor investment with very little return. We had some interesting, lively discussions about the illegality of most of the drugs we were talking about. And we were certainly clear that beyond a certain point, there seemed no benefit and possibly increased harm from the more draconian measures that would be applied through the illegality, and that even if the illegal status was seen as important, a much lighter touch was required than widespread incarceration. Okay, that's okay. That substantial investments, particularly in the opiate addiction field, seem to give very good financial returns, with reductions in drug-related problems for the individual, their family, and society. And that's consistently been shown in studies over time and across cultures. That schools, family, and other prevention programs have generally been disappointing, Previously, 10, 15 years ago, we would have said we don't have evidence of their effectiveness. We now do have evidence, and it's quite well demonstrated the weakness of the benefit. There may be a later generation of prevention programs which are more effective, but the ones studied thus far have generally been very disappointing, considering the size of the budget they take. There are false dichotomies in the public debate which mislead us. These are the notions that it's law enforcement in competition with a treatment option, where we would argue for looking at ways of harnessing the two to work together. The mistaken view that it's either abstinence versus harm reduction, or legal versus illegal drugs, or drug users versus society. These are mistaken distractions. We always need to be aware of the perverse impacts of drug policy, which are widespread, that whatever your intentions, there may be unintended consequences. The legal pharmaceutical system often is woven into the nature of a country's drug problem and increasingly needs to be borne in mind, particularly with wider internet availability and such. And that there is virtually no scientific research, very poor quality scientific research, studying supply control and law enforcement. And this needs much more serious study. So in conclusion, we were saying it's disappointing that some of these areas have not been as rigorously studied as some of the other areas. But despite that, there are some areas where we can now give a clear conclusion that there are interventions of little benefit and other interventions of major benefit, and that current national and international policy doesn't follow that, doesn't match that as exactly as it ought to. Thank you very much.